Aloha from Vietnam. First of all, I would like to pay my gratitude to GE who gave me the opportunity to deliver presentation today. My topic today is about a systematic approach to the diagnosis and management the complication of monochorionic pregnancy. Prevalence of teen pregnancy is about 1 in 250. Diagnosticity refers to the time of conception. 2/3 of all teens are dizygote and 1/3 of all teens are monozygous. Chorionicity denotes the time of placentation. 2/3 of monozygous are monochorionic and nearly almost monochorionic twins are monochorionic diamniotic twins. And we know that the chorionicity rather than the zygosity determine the outcome of teen pregnancy. Monochorionic teen pregnancy are at increased risk of adverse outcome, most because of the vascular anastomosis that connect the two fetal circulation systems. The shared circulation is responsible for some unique complications in monochorionic teens such as TTTS, TAP, or TRAP. And the second pathogenesis of monochorionic teens is unequal division of the shared placenta. This appears to be the most important determinant of discordant growth in the monochorionic teen. Placental vascular anastomosis can be of three types. Arterial, veno-venous anastomosis can protect against the development of TAP or TTS because bidirectional nature allows for the inter-teen equilibration of the blood volume, while arteriovenous with the unidirectional nature can create a transfusion imbalance leading to the severe complication like TTS or TAP. Ultrasound plays a key role in screening, diagnosis, and management the complication of monochorionic teen pregnancy. We should follow the practice guideline about the roles of ultrasound in teen pregnancy issued by ISO. And we know a very important role of the 12-week scan is to determine the chorionicity and amnionicity. And most of you already know with the lambda sign is a dichorionic diamniotic twin, and with the T sign is a monochorionic and diamniotic twin. And this is the ISO recommendation about time, frequency, and content of the ultrasound assessment for monochorionic teen. And you can see the patient is scanned every 2 weeks from 16 weeks to the end of pregnancy. And now we move to the diagnosis and management the complications that are specific to monochorionic teen pregnancy. Twin transfusion syndrome is the most severe complication in monochorionic teen pregnancy. It occurs about 1 in 10 of monochorionic teens and from 16 weeks to 26 weeks of pregnancy. Twin transfusion syndrome occurs if there is imbalanced fluid flow through relatively large placental anastomosis. And the consequence is the donor twin is hypovolemia, polyuria, and the recipient twin is hypervolemia and polyuria. The diagnosis of twin transfusion syndrome is based on the presence of one twin with the polyhydramnios and the other twin with the oligohydramnios. Oligohydramnios is defined as the deepest vertical pockets under or equal to cm, and because the amniotic fluid increases with gestation, so polyhydramnios is defined as the deepest vertical pockets above 6 cm before 16 weeks, deepest vertical pockets above 8 cm before 20 weeks, and deepest vertical pockets above 10 cm after 20 weeks. Once the diagnosis of TTS is established, the severity of the condition may be assessed using the quintiles staging system. Stage 1 if the bladder of the donor twin is visible. Stage 2 if the bladder of the donor twin is non-visible. Stage 3 if there is critical abnormal Doppler in the donor twin, like the absent or reverse and diastolic velocity in the umbilical artery, absent or reverse flow in the ductus venosus, or pulsative flow in the umbilical vein. Stage 4, if the recipient is hydro, and stage 5, demise of either twin. Remember, TTS is not a homogeneous disorder. It may coexist with selective fetal growth restriction and or with TAP. In a study by Grun and Tollner, 60% of TTS associated with selective fetal growth restriction, and TAP detected in 50% of TTS twins prior to laser surgery. How about the management of twin-twin transfusion syndrome? We know that if untreated, the perinatal loss rate of TTS may up to 70 to 90%. Until now, fetoscopic laser coagulation of the vascular anastomosis is the optimal treatment for TTS. And you can see here in a very large study, including 1,020 pregnancies with TTS by D and NO, they report the overall survival rate for both fetus is about 63%, and the overall survival rate for at least one fetus up to 86.7%. When twin transfusion syndrome is indicated for laser surgery. Symptomatic TTS stage 1, TTS stage 2, TTS stage 3, and TTS stage 4. How about the asymptomatic TTS stage 1? In a multi-centric randomized by experiment in 2021 in 9 fetal medicine centers in Europe and US, asymptomatic women at TTS stage 1 from 16 to 26 weeks with the cervix above 15 mm were randomized between expectant management and immediate laser. The outcome were the survival at 6 months with rather severe neurologic morbidity, and you can see there were no difference in the outcome between the expectant and laser treatment. So they include, it is unlikely that the early fetal surgery is of benefit for stage 1 twin transfusion syndrome in asymptomatic pregnant women with a long cervix. And now we move to another complication of monochorionic twin pregnancy is selective fetal growth restriction. This occurs in about 12 to 25% of monochorionic twins, with a high rate of fetal demise and long-term neurological impairment. And in contrast to TTS, very little is known about the optimal management and outcome in selective fetal growth restriction. The pathogenesis of selective fetal growth restriction is a combination of unequal placenta sharing and blood flow interchange through placenta anastomosis. So the diagnosis is based on a large inter-twin growth discrepancy. As in a consensus definition and essential reporting parameter of selective fetal growth restriction in twin pregnancy, for solitary parameter, we need only one fetus had the estimated fetal weight under 10%. For the contributory parameter, we need at least 2 or 4. Estimated fetal weight under 10%, abdominal circumstance under 10%, discordance between two fetus above 25%, and the PI umbilical artery of the smaller twin is above 95%. Grotacode classifies selective fetal growth restriction into 3 types depending on the pattern of the end diastolic flow in the umbilical artery Doppler. Type 1, if the end diastolic flow is positive. Type 2, if the end diastolic flow absent or reverse. And type 3, if the intermittent, the absent and then present and then absent or reverse of end diastolic flow in the umbilical artery. In contrast to TTTS, the optimal management for selective fetal growth restriction remains unclear. More studies are required to determine how and when the pregnancy should be treated antenatally. And you remember that our goal of treatment is not only chance of survival, but also disease-free survival baby. This means the baby no cerebral injury and long-term neurodevelopment impairment. A difficult decision in management selective fetal growth restriction is when to induce delivery. It's a balance between prematurity and dismay. If we deliver at too early age, this may lead to complications associated with severe prematurity, including neonatal mortality and cerebral injury, while delivering this baby too late may also be associated with an increased risk of single or double fetal mortality and also cerebral injury in case of single fetal death. So the management decisions in selective fetal growth restriction are currently not based on evidence, rely primarily on expert opinion, and vary greatly between the centers. In a last study by Cook about the outcome of monochorionic with selective fetal growth restriction at 16 weeks, 20 weeks, and 30 weeks, according to new DNFI consensus definition, they reported the prevalence of selective fetal growth restriction up to 26%. The early onset occurred in 73% and majority is type 1. The overall survival rate about 88%, with 82% is survival for both twins. Subsequent developing type in 3% and TTTS in 10%. So they conclude patients can be informed that the selective fetal growth restriction had good outcome. The survival rate above 90% in the absence of TTTS, abnormal umbilical artery flow, type 2 or type 3, and majority anomaly. How about the prognosis of early and late onset selective fetal growth restriction? Early onset is defined if occurred before or at 24 weeks, and late onset if occurred after 24 weeks. And in a study by Curado, you can see the prevalence of early onset or late onset nearly the same, 5% and 4%. However, early onset selective fetal growth restriction associated the worst perinatal outcome. As you can see, the incidence of type 2 and type 3 in early selective is 19.2% compared with the late onset only 5.6%, and the superimpose of TTTS is more common, 26% in early onset compared with only 5.6% in late onset. We know that unequal cell placenta is the main reason of selective fetal growth restriction. How can we recognize an equal cell placenta in a monochorionic twin? We can look for the cord insertion. And you can see in a study by Calafat, the incidence of birth with discordance of 25% or more were significantly higher in pregnancy with filamentous or marginal cord insertion compared to those with normal cord insertion. So they conclude sonographic delineation of placenta cord insertion should be valued in antenatal stratification of teen pregnancy. And now we move to another complication of monochorionic twin is twin anemia polycythaemia sequence. Twin anemia polycythaemia sequence can occur spontaneous in 5% of monochorionic twin and up to 16% of cases after laser treatment for TTTS. It can develop across the entire second and third trimester. So the time of onset of spontaneous TAP may be from 15 to 35 weeks, And in case post-laser treatment, TAP usually occur within 1 month. And remember, TAP may coexist with TTTS and selective fetal growth restriction, and TAP in monochorionic monoamniotic or in dichorionic diamniotic also reported. Why TAP occurs is proposed by slow and chronic unbalanced fetal-fetal transfusion through minuscule placenta anastomosis under 1 mm, and this leading to anemia in the donor and polycythemia in the recipient without sign of TTTS. And the mechanism thus prevents TAP donor to develop oligohydramnios and TAP recipient to develop polyhydramnios not clearly understood. The hypothesis is that slow transfusion allows more time for a hemodynamic compensatory mechanism to take place in TAP. As TAP is established, we need to diagnose stage 4 management. Stage 1, if MCA-PSV of the donor above 1.5 mol and the recipient under 1 mol, or the delta MCA-PSV above 0.5 mol. Stage 2, if the MCA-PSV of the donor above 1.7 mol and the recipient under 0.8 mol, or the delta MCA-PSV above 0.7 mol. Stage 3, if the stage 1, stage 2 combined with the cardiac compromise of the donor. Stage 4, if the donor is high growth, and stage 5, if the intrauterine demand of one or both fetus preceded by TAP. In a recent consensus, diagnostic criteria and monitoring of twin anemia polycythemia sequence Denvia procedure by Professor Kalin, we had 2 criteria. First, MCA-PSV in the donor twin above 1.5 mol and in the recipient under 0.8 mol, or MCA-PSV discordant above 1 mol. Although MCA-PSV discordant is the cornerstone of the diagnosis of TAP, additional ultrasound marker associated with anemia and polycythemia have also been reported, like sterile sky liver of recipient twin is caused by the hyperechogenic congested portal venue and diminished liver parenchyma. Another additional ultrasound finding is dichotomous placenta. The placenta of the donor is enlarged and hyperechogenic compared with the recipient. The placenta is flattened and hypoechogenic. In a recent study by Tollner, majority of TAP twins presented with at least one marker, like dichotomy in 44%, stereocysteine liver in 66%, and cardiomegaly in 70%. And the presence of the marker might indicate a poor prognosis is unclear. We need more future research. How about the management for TAP? There is no consensus on the best treatment for TAP. With the expectant management of preterm delivery, the baby has no risk of intrauterine treatment. TAP can resolve spontaneously, or we can treat anemia and polycythemia in the neonatal intensive care. Intrauterine blood transfusion may be indicated in case of severe anemia. For laser surgery, technical problem because the absence of polyhydramnios and selective fetal size can be indicated in the case of severe early onset. And now we move to the last complication of monochorionic twin is the twin reverse arterial perfusion. TRAP sequence is a rare condition of monochorionic twin, about only 1%, and two criteria be necessary for the development of a TRAP. First, the presence of arterial anastomosis and an intrauterine demise of one of monochorionic twin, allowing for the reverse of blood flow. So whenever a single intrauterine demise of the monochorionic twin diagnosed in the first trimester, TRAP sequence should be kept in mind. The perfusing is supplied by the oxygenated, resulting deficient in development of the head, the heart, upper line, and the pump twin may develop high output cardiac failure, high growth, polycythaemia, and consequent premature delivery, and the mortality reported up to 50 to 70% of pump twin. A cardiac fetus had a specific finding on ultrasound, subcutaneous edema, irregular cardiac activity is made from the rudimentary heart beating or a retrograde pulsation from the pumpkin twin. The head, the upper body, and the upper extremity are poorly developed, while the lower body and the lower extremity are usually less anomaly, and the reverse flow in the umbilical cord confirm the diagnosis. The acardious acephalus is the most common type of the TRAP, about 60 to 70%, and these twins do not develop a head but may have an undeveloped skull base. Acardious ancest is the most developed form, about 10% of TRAP. This form has armor, legs, and a partially developed of head with the brain tissue and facial structure. For management of TRAP sequence, the size of the acardiac twin play an important role in the pathogenesis of complication in the pump twin. So we need to calculate the weight of the acardiac twin. Acardiac anomaly are also divided into two types. Type 1, small or medium-sized acardiac twin, when the abdominal circumference ratio under 50%, and type 2 is the large acardiac twin, when the abdominal circumference ratio is above 50%. The main goal of the management of TRAP is to preserve the survival of the pump twin reaching the term of delivery. So optimal timing of intervention is still to be clarified, and technique of choice, laser coagulation and radiofrequency ablation of the intrafetal vessel are preferred approach. And the last I would like to mention is the single fetal death. What happens if a fetal death? Circulating volume will be from the survivor to the destined. The survivor will be hypotension, will be hypoperfusion of the brain and other organs. The brain will be damaged, and finally the fetal may be dead. Monochorionic twin with a single fetal death must be managed in a tertiary level center, including detailed scan Doppler, fetal brain 4 to 6 weeks after later, and delivery at 34 to 36 weeks. Remember, an organ delivery may be too late to prevent long-term morbidity, so if preterm, prolonging the pregnancy for the benefits of the surviving twin. In a study by Markey about the prognosis of the co-twin following spontaneous single intrauterine fetal death in twin pregnancy, the prevalence about 6% of twin pregnancy and preterm birth up to nearly 60%, and the abnormal antenatal brain imaging report in up to 20%. And I would like to share with you an interesting case. Acardiac triplets is the acardiac is a live fetus, and this is another demise fetus. And you can see the survival later had the damage of the brain with the absence of the corpus callosum and the hydrocephalus, and damage of the brain tissue can confirm with the MRIs. And the key home message of my talk today: at 12 scan, we must determine this is a monochorionic. And then for 90 ultrasound examination, it means that every 2 weeks we have to do ultrasound to assess the biometry, amniotic fluid volume, Doppler, including umbilical artery and PSV-MCA. If one baby with a polyhydramnios and one with oligohydramnios, it may be a TTS. If one twin and the estimated fetal weight under 10% and the estimated fetal weight discordant above 25%, is a selective fetal nutrition. And if the delta mom of the PSV-MCA above 1 is a TAP. And remember, TTTS may combine with the selective fetal nutrition or TAP, and TTTS also combine with TAP. Thank you for your attention.
So thank you, Dr. Nguyen, for giving us the wonderful lectures. So we will go ahead and take some time for questions now. So just a reminder that you still can submit question through the question box. So the first question is, please describe Doppler finding in donor and recipient fetus.
Okay, let me share screen.
Yeah, Dr. Nguyen, you can share screen now.
So the first question, you asked me about the Doppler finding in the donor and recipient of the twin transfusion syndrome. So for the TTTS syndrome, we diagnose based on the discordant in the hydramnios, one with the oligohydramnios and one with the polyhydramnios. And when you diagnose the TTTS, the next step, you must diagnose the state, because it will let you can manage how to manage the TTTS and predict the outcome. And for the Doppler, you need to do the Doppler of umbilical. And you remember, for a twin, you do the position to do the umbilical umbilical artery. You need to do at the position that the umbilical artery insert to the body of the baby and bilateral of the bladder. So you sure it be the umbilical artery of the twin that you want to do. You don't miss with the other. If you choose a free cord artery, you have to choose at the bladder position to do the Doppler. And you remember, for the TTTS or a monochorionic, every 2 weeks, we have to do the umbilical artery assessment Doppler, and it depends on the Doppler of the umbilical artery. If you can see if the baby, the donor, know the positive, the diastolic flow positive, it means the type 1 or type 2, and if the absent or reverse, it is the stage 3, and the prognosis may be not good at the stage 2 or stage 1. So it depends on the umbilical artery. Is the end diastolic of the artery is positive or absent or reverse, we can diagnose the stage. Yes, and this is for the donor team.
Thank you, Dr. Wing. Yeah. So the next question is, how can we diagnose selective fetal growth restrictions in twin transfusion syndrome?
Okay, and another good question. And you know that for in the monochorionic thing, this is very common. We make the confuse between the selective fetal growth restriction and TTTS, and the important because both complication TTTS are selective fetal growth restriction. You will see one fetus smaller, oligohydramnios in the smaller, and abdomen or Doppler. But the different important key to make the different diagnosis, because TTS is you look for the amniotic of the bigger, it means the normal baby, normal or polyhydramnios. If polyhydramnios, it means TTTS, and if the bigger twin, the normal twin, had the amniotic fluid normal, it means the selective fetal growth restriction. So first you must clarify between the TTTS and selective fetal growth restriction, because two complications may be misdiagnosed together. And so when you do the selective fetal growth restriction, you can, based on the consensus diagnosis of the DFI in the consensus in 2019. And if one fetus, it means the smaller, has the fetal weight, estimated fetal weight under the 30%, it means they're very small. You don't need the discordant or the abnormal of Doppler. You do the selective fetal growth restriction. And if the smaller baby, the estimated fetal weight not too small, it means from the 30% to 10%. It's not too small. You need another parameter. Another parameter may be the discordance between two fetus above 25%, or the abnormal of, it means the PI of umbilical artery of the smaller twin above the percentile 95. So it means, so you can do the diagnosis. It depends on the too small is very easy. No need to see the other factor like the Doppler or the discordant. But if not too small, just 3 to 10%, we need to do combine with abnormal or Doppler or the discordant of two fetus. Thank you.
Thank you, Dr. Nguyen. The next question is, what color Doppler finding in donor of twin transfusion syndrome is important?
So for the TTTS, if you diagnose the state just based on the abnormal or umbilical artery, but for the prognosis, you can do the other Doppler of the ductus venosus or the Doppler of the umbilical vein. And when you see the abnormal of ductus venosus or the pull, the abnormal on the vein, normally we don't see the pull, but when you see, it means that the state E works and predict the worst outcome, because the baby had a very severe situation, and the heart may be failure. So maybe the treatment, maybe the successful treatment may be not good as compared with the earliest the other stage.
Thank you, Dr. Nguyen. The next question is, what is the normal umbilical Doppler in selective fetal growth restriction? Thank you, doctor.
So the Doppler of the Doppler, I also say the answer for the Doppler, the abnormal Doppler on the selective fetal growth restriction, you do the you do on the only the umbilical artery, and this is it depends on the let me show you because the strata code define define 3 types, and the study showed that if the type 1 is good prognosis, it means the end-diastolic flow positive. It means the good prognosis and the successful treatment very high. But when the donor thin where had the absent or revert, it's the type 2 is not good compared with the type 2. And between the type 2 and type 3 is mean that the end diastolic intermittent positive, then absent, and then revert. It means it may be that it's either it may be the early stage of the type 2, and the prognosis of type 3 is not good as type 1, but type 3 may be better than type 1. Yes, so compare a study show that if we compare the type 2 and type 3, the type 3 may be better than the type 1, type 2, but the type 3 is not good. The prognosis, the successful of the treatment TTTS, the laser treatment is not had the high successful like the type 1.
Thank you, Dr. Nguyen. So the last question is, when should monochorionic twins be delivered?
Oh, very, it's a very complex question. You know that for the, it depends on the baby had which complication. For the TTTS on the selective fetal growth restriction, it depends for the TTS when you had the baby grow is not for with the good outcome get better and you can delivery, and when they had the complication with the severe TTTS type 3 or type 4, or for the selective fetal growth restriction, when the smaller, too small, and had the risk of the fetal death, and we may lose the other fetal. So it depends on which complication of the monochorionic, and for the treatment and experiment of TTTS is clearly for the management of TTTS complication, because the laser treatment had a better outcome and the time for the delivery. But for the other complication like selective fetal growth restriction or TAP or TRAP, you can see here the optimal management remain unclear for even the selective fetal growth restriction or for TAP. It has many different management and the time to delivery. So it's really a complex question for the answer, but we have to balance between the premature free. If you get the baby out, baby had the complication for the premature of fetal brain. If you continue to keep the baby in the uterus, one fetus maybe die. And you know, for monochorionic, one fetus died, the second had the risk of the die because the connection anastomosis between the two tin in the placenta. So when a fetus die, it collapse and the blood from the survivor will move to the demise, and the liver, the survivor will be a hypotension, will be lost blood, and maybe die in just 24 hours. So very, very risk for the survivor and for the decision. I think this is to deliver, and for the management really very important. The baby must have to manage in high in a territory with the experienced prenatal diagnosis doctor. Yes, so it's a really complex and difficult to make the decision.
So thank you, Dr. Nguyen. So it's look like we cover all the questions. So Dr. Nguyen, is there anything else you want to cover before I wrap up?
Yes, so you know that's for the monochorionic. You see for a monochorionic, the complication, the TTTS is the most common, but we can diagnose it very good. And for the outcome, the very clearly evident for the treatment, laser treatment. But for the other complications like selective fetal restriction or TAP or TRES, also sometimes we miss. And for the management, also difficult decision. So for the ultrasound, for the prenatal diagnosis doctor, I think from the 12 week, we must we have to determine very exactly at the 12 week scan to recognize, to identify the monochorionic diamnitin. And then from a 16 week, we have to follow up to scan every 2 weeks. And you know, for TTTS, it occurs from the 16 to 26 weeks. After 26 weeks, no TTTS. But for TAP, it can occur through the second to the third trimester from 16 weeks to 35 weeks, not after 26 weeks like before. Now, the studies show that the TAP can occur from the 16 to 35 weeks. So every time we have to measure the MCI-PSV, and when we say that the discordant in the MCI-PSV, we can have for better the diagnosis and for better the management. So I think for the monochorionic selective monochorionic complication, now we have more and more evidence for the treatment, for the diagnosis, but some complications still very difficult to have clearly for the evidence about the optimal treatment.
Thank you, Dr. Nguyen. So we have come to the end of our webinar. I would like to introduce the next webinar, Slow Flow HD for the examination of endometrial receptivity and implantation in assist reproductions, presented by Professor Laurel from Department of OB and GYN, Eastern Virginia Medical School in USA. So this webinar will happen in next week, Wednesday, 18 May. So, and once again, thank you everyone. We appreciate you being here. And thanks again for joining us today. We will see you next time soon. Thank you, Dr. Nguyen and everyone.
Thank you, Julie. Thank you, everyone. Have a nice weekend. Bye-bye. See you next time.
Thank you very much, Dr. Nguyen, for your passionate lecture again. We hope to have you again for another great session in the near future.
Sure.
Thank you very much again.
Bye-bye.
Bye-bye.
Good night. Bye-bye.